Department of Medicine, and we'll be speaking on the immunosuppressive medication for ocular disease, the rheumatologic perspective. Thank you.
Thank you. I would like to thank the organizer for inviting me to this meeting. First, I was assigned to talk about the immunosuppressive agents for inflammatory ocular diseases. But I feel that no one can understand the disease, the activity and severity of ocular disease no better than the ophthalmologists themselves. So my talk is about the inflammatory extraocular diseases. So some medication that can be effective in the ocular diseases may not be effective at all in the extraocular manifestation of rheumatic diseases. And this is my disclosure. The outline of my talk is about the common rheumatic diseases, but I think everybody knows about this one. And the main topic is about reviewing the immunosuppressive agents available in the treatment of rheumatic disease for ocular and extraocular diseases. This is my references. For common rheumatic diseases that cause inflammatory eye diseases from the outside from keratoconjunctivitis sicca, the commonest one is the Sjogren disease, or Sjogren syndrome, and rheumatoid arthritis and systemic sclerosis. And the next is the episcleritis or scleritis. There are a lot of causes of this manifestation from the systemic rheumatic disease to the vasculitis syndrome. For uveitis, from anterior, intermediate, posterior, or panuveitis, you see that a lot of inflammatory arthritis, vasculitis, or autoimmune diseases can cause the eye diseases. And the posterior one, including the retina, there are a lot of diseases that can cause the retinal vascular disease. So, from my perspective, actually I have to complete it within 15 minutes, so it will be very fast. So I will talk about some, for particular, the glucocorticoids, which is mostly used for treatment of inflammatory eye disease, and the groups of disease-modifying anti-rheumatic drugs, which can improve the arthritis and delay the joint damage, and improve the function and quality of life of the patient. Some can be used in inflammatory ocular diseases, but some cannot. And I would like to focus on the last one, the new one, the JAK inhibitor, which can inhibit the intracellular signaling pathway, the tofacitinib, which is already approved for the treatment of rheumatoid arthritis, but it will be a new one to be treated in inflammatory eye diseases. And for the biologic agents, we will describe as TNF inhibitors and non-TNF inhibitors. And for immunosuppressive agents, the older cytotoxic agents, which nowadays is rarely used, but it still be more effective in some refractory patients. Glucocorticoids, I think everybody knows, and I think everybody here used it at least once. So prednisolone is the most common initial prescribed drug for inflammatory arthritis and inflammatory condition, which is not infectious in origins. And glucocorticoids can reduce the signs and symptoms of inflammation and maybe mask the symptoms of infection also. So it will be, very hard to consider when you use glucocorticoids, especially in the moderate to high dose. For moderate to high dose, the use of steroid can cause a long-term safety concern. So 20% of the human leukocyte transcriptomes are influenced by glucocorticoids. And glucocorticoids can act through the genomic and non-genomic pathway. The non-genomic pathway is very fast, so it can be seen that when you use the steroid at a very high dose, the pulse methylprednisolone, it acts through the non-genomic pathway, so that's why it can act within hours or days. But for genomic pathway, that it has to be engaged to the glucocorticoid receptor and then inhibit the pro-inflammatory cytokines genes transcription. So it may take about weeks to work. So that's why when you use the lower dose of glucocorticoid from low dose, moderate dose, or high dose, it will act later than the mega dose. For systemic glucocorticoids, it won't work in every rheumatic diseases, especially those with spondyloarthritis. You cannot use, it won't work in ankylosing spondylitis or reactive arthritis. It may work in psoriatic arthritis, but it can cause flares of the psoriatic plaques. And systemic sclerosis, it may cause the major side effect, the scleroderma renal crisis, which can be life-threatening. So you have to be careful when you use systemic glucocorticoid in certain rheumatic diseases. I won't talk about anti-malaria drug, and I will describe some in the sulfasalazine. Sulfasalazine is the compound with two molecules attached together with a double end bond, and it works with spondyloarthritis and rheumatoid arthritis. And it's claimed that sulfasalazine may help reduce the recurrent rate of uveitis in some spondyloarthritis patients. But it's not effective in lupus, in systemic sclerosis, or in Behçet's or vasculitis syndrome. And in lupus, it may cause the adverse skin effect in this patient. For methotrexate is the anchor drug for rheumatoid arthritis treatment, and it is also effective in the treatment of polyarthritis in several diseases, and it's also the glucocorticoid sparing agents in lupus, in inflammatory muscle disease, including dermato or polymyositis, and systemic sclerosis, relapsing polychondritis, a limited form of granulomatosis with polyangiitis, the new name of Wegener's granulomatosis. For methotrexate in psoriatic arthritis, it can improve the skin and the joint symptoms. The usual dose of methotrexate is starting from 7.5 to 10 milligrams per week and gradually increased to 20 to 25 milligrams per week. But for the dose of over 15 milligrams per week, I recommend that the parenteral form, the subcutaneous form, is preferred because the absorption is better, 100%, and the side effect, especially the liver toxicity, is lower, it's much lower. And don't forget to give folic acid of at least 1 milligram per day together with methotrexate. And in rheumatoid arthritis, methotrexate can be given as a monotherapy or together with other DMARDs. Leflunomide is almost the same with methotrexate, but it inhibits the pyrimidine synthesis. It can be used as monotherapy and combined with methotrexate. And the toxicity is almost the same with methotrexate. And it's also used in peripheral arthritis, in psoriatic arthritis, and juvenile idiopathic arthritis. For the calcineurin inhibitors, the cyclosporin and tacrolimus, it can be used as a combination with methotrexate for rheumatoid arthritis and psoriatic arthritis. And both of them can be used in the lupus nephritis, especially in membranous glomerulonephritis. The synthetic targeted synthetic DMARDs, the new one, is the JAK1 and JAK3 inhibitor, the tofacitinib. It is proven effective in rheumatoid arthritis as a monotherapy, or it can be combined with methotrexate or other DMARDs. And don't forget to give it together with azathioprine, cyclosporin, or tacrolimus, because it will enhance the toxicity, especially the myelosuppression. And the data in psoriatic arthritis are coming. For the older cytotoxic agents, the cyclophosphamide is still the mainstay for treatment of refractory severe life-threatening organ involvement in rheumatic disease, especially the inflammatory eye diseases. So it's the potent immunosuppressive agent that inhibits the DNA transcription. So it can be used as the induction agents for the lupus nephritis and other severe major organ involvement in lupus, in vasculitis syndrome. And for vasculitis syndrome, the use of oral, daily oral is better than the IV pulse, but given a lot of toxicity. But cyclophosphamide is not effective in spondyloarthritis. Azathioprine is another agent that can be used as a glucocorticoid sparing agent, and it can be used as the maintenance phase for lupus nephritis or other major organ involvement in lupus and Sjögren. And the treatment of choice of Behçet's disease are the inclusion of azathioprine in the treatment regimen. But azathioprine used the same metabolism with allopurinol and sulfasalazine. So when you give these two together with azathioprine, it will enhance the toxicity, especially the myelosuppression. And it doesn't work in spondyloarthritis. For the mycophenolate and mycophenolic acid, and both are used as the induction and maintenance of phases of lupus nephritis. It can be used in refractory cutaneous lupus and other autoimmune disease like inflammatory muscle disease, polydermatomyositis, and some vasculitis if they cannot tolerate the cyclophosphamide or they are not response to azathioprine. For chlorambucil, the very old and toxic one, so we still use very, very rarely, but in some cases that cannot reimburse for the TNF inhibitors, they can be used in neurobehçets or some severe or refractory conditions. For the TNF inhibitors, in Thailand we have only 3 TNF inhibitors here. The etanercept, which is the soluble TNF receptor fusion protein, and the 2 monoclonal antibodies, the infliximab and golimumab. Etanercept is effective in rheumatoid arthritis, spondyloarthritis, and polyarticular JIA. And both the monoclonal antibodies are used in rheumatoid arthritis, spondyloarthritis, and inflammatory bowel diseases. And both are used and effective in Behçet's and giant cell arthritis. For non-TNF inhibitor biologic agents, we have rituximab, which is the anti-CD20 monoclonal antibody, which acts on killing the B cell, which can be used in rheumatoid, in lupus, in Sjögren, and Wegener's. For anti-IL-6 receptor monoclonal antibody, tocilizumab, there are several indications to use. And the last one is CTLA-4 immunoglobulin or abatacept, which is has the lowest infectious risk among these biologics. They can be used in rheumatoid arthritis and Behçet's. In the next 2 or 3 slides, I will give you the monitoring, how to monitor the immunosuppressive agents when you use, because some have a lot of side effects, especially for the myelosuppression, the liver or kidney toxicity. So methotrexate and leflunomide, both of agents, they have toxicity to the liver and the myelosuppression. So you have to monitor the CBC, the liver function test, and the function of liver for the synthesis of albumin, and chest X-ray, because they may cause the interstitial lung fibrosis. And for the cyclophosphamide, they can cause the hemorrhagic cystitis, so you have to monitor the urine analysis also. And for the azathioprine, mycophenolate, and chlorambucil, they have the same monitoring regimen. Glucocorticoids, we have a lot of complications, especially long-term. For in Thailand, we have a lot of infection. A lot of patients on long-term glucocorticoids, they always have salmonella infestation in the bowel, so you have to do the monitoring of stool culture or stool exam for parasites and salmonella infection and treatment from time to time, because it may cause the septic arthritis. And it also reduces the bone density, so you have to monitor the bone mass density every 1 to 2 years. For the biologic agents, the TNF inhibitors, rituximab and abatacept, you have to be prepared that the patient, before using these agents, the patient has to be free of hepatitis B, C, HIV, or tuberculosis before giving these agents. And then you have to monitor the blood test and chest x-ray, because it can cause tuberculosis or fungal infection in the first 2 or 3 years after treating with the TNF inhibitors. For tocilizumab, it's also the same, but it can also increase the lipid profile very, very much. So you have to monitor the lipid profile occasionally. And some patients may get pregnant while you use this kind of medication. For systemic immunosuppressive agents, some can be used with caution in pregnancy, but most cannot be used because they always secrete in the milk. So everyone have to be cautious about using these agents in pregnant patients. Okay, so thank you for your attention.
Excellent overview of the numerous medications employed in treatment of rheumatologic disorders. We thank you very much. Now we're going to switch back